Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Pediatric Seizures, Episode 4, Special Considerations. After watching this episode, participants should be able to review febrile seizures in infants and toddlers, review atypical seizure presentations in infants, children, and teenagers, review treatment of atypical non-convulsive seizures, and review impact seizures in infants, toddlers, and school-aged children.
So parents often ask us in the setting of having a febrile seizure, that is a fever seizure, or a child who has a seizure when their temperature changes very, very quickly. They ask us, does my child now have epilepsy? Is my child always going to have seizures? And in general, the answer to that question is no. Febrile seizures, or seizures in the setting of an illness, are usually a special situation. There are children who will go on to have a seizure disorder and seize just because having a fever makes it more likely in the setting of a seizure disorder that you will seize. However, otherwise healthy children who have a simple seizure in the setting of a febrile illness go on to lead perfectly happy, normal lives. In fact, our neurology colleagues will say that a child would need to have upwards of 7 febrile seizures before they would get concerned that there might be a problem. Now within that, there's different classifications of seizures in the setting of illness. The overwhelming majority of children will have a generalized seizure that lasts less than 15 minutes in the setting of illness, and that is a very reassuring sign. However, if a child was to have a seizure longer than 15 minutes, or a focal seizure, meaning just one body part was moving, that would be much more ominous and concerning for perhaps meningitis or some other more dangerous illness at work. But again, the overwhelming majority of children who have a seizure in the setting of a febrile illness go on to do just fine, and it's considered a totally separate class of illness. These children rarely need medications in the field to stop their seizures, other than, of course, maybe some Tylenol or Motrin to help get that temperature down.
Febrile seizures are seizures occurring in the presence of a fever without other neurologic causes. They generally occur in children between the ages of 6 months and 6 years old and will occur in approximately 3 to 5% of children in this age group. The febrile seizure most commonly occurs in the first 24 hours of an illness and is often the first sign of the fever.
Everyone tends to think of seizures as the generalized tonic-clonic or grand mal type seizures, where everything is shaking and the person is not conscious. But there are several other seizure types that are a little bit more complex and may just be associated with behavioral changes. Several seizure types, including temporal lobe epilepsy, are just associated with patients having abnormal sensations in the sense of abnormal smells, abnormal lights and colors in their vision, impaired consciousness in the sense that they are staring off and not interacting with you, and sometimes very strange behaviors, so very similar to psychosis. In addition, there are other types of seizures, the absence type seizure where the patient just kind of stares off. Sometimes they're associated with automatisms, we call them, so lip smacking, hand wringing, or funny movements of the hands that are rhythmic. And though they may actually even be able to follow some commands, they're still having significantly impaired consciousness and are still actively having a seizure if you could hook up the EEG leads to them at that time and see their brain activity. There are certain kinds of seizures that happen more commonly at night, but not always, again associated with big behavior changes called frontal lobe epilepsies, where a patient behaves essentially like they're sleepwalking. They may be able to have a coherent conversation, they may be having very complicated activities in the sense that they're running, in the sense that they're hitting things, that they seem to be reacting to their environment similar to psychosis, but are in fact having a seizure. There are even seizures called cursive seizures, where a patient just starts to run. And their consciousness is impaired, they're not really awake and alert, they're just running. But this is a very rare seizure type, and most commonly people know that they have it before you arrive. The atypical seizures do need to be treated in the pre-hospital setting because, again, even though they're primarily of behavioral phenotypes, they still can cause brain damage by continued seizure activity. In the setting of knowing that the patient has an underlying seizure disorder that is of atypical presentation and it's been going on for more than 5 minutes, that still constitutes status epilepticus. It is not as dangerous to the patient as is generalized tonic-clonic or one of the other types that is causing a physical manifestation of the seizure activity, but should still be treated similarly with midazolam in the field if you know that the event has been going on for a prolonged period of time.
Impact seizures are unique to the pediatric population for the most part. There are a group of children out there, for reasons we don't really understand why, who are prone to having what we believe to be syncopal events in the setting of emotional stress. This is classically a toddler who is known to have frequent temper tantrums, and what will happen in the setting of what's perceived as a very minor trauma, for example, a 2-year-old fighting with a 5-year-old over a stuffed animal. That 2-year-old might grab the stuffed animal from the sibling, incidentally bop himself in the head with a stuffed animal, which should not cause any injury, but just become very upset because there was a fight occurring, and then they perceive themselves as being injured. This is a big emotional stress to the toddler. They then go on and actually have a fainting event, but there often is some shaking involved with this, and they appear to have a seizure. So we usually call these impact seizures. They usually do also fall down to the ground, and then of course can have a second impact, but again, somebody who's very short, as a toddler is not very likely to cause a significant trauma to themselves. These are very benign conditions. These are usually children who are known to have breath-holding spells, a situation, again, that very, very scary to the parents, but is actually not dangerous to the child, where in the setting of an emotional stress will have a bit of a tantrum, hold their breath, and often will pass out. Children often will have a situation also in the setting of syncope where they simply are not allowed to fall down or placed down on the ground fast enough. Anytime a person remains in an upright position in the setting of passing out, that makes it even more difficult for appropriate blood flow to reach their brain. And in that situation, a patient will often have some myoclonic or myotonic jerking that can certainly mimic seizure activity. Again, these are not standard seizures, and this does not mean the person will go on and have epilepsy or have any dangerous side effects from this happening. Of course, a child could have a seizure in the setting of a significant trauma, so when evaluating these types of patients, you'd want to make sure that they did not have any bruising, they did not have any other abnormal findings on their exam. But far and wide, my experience has been that by the time EMS arrives, the child has regained consciousness and actually is back to their total normal baseline without any sequelae of the potential seizing event.
After watching this episode, participants should now understand that febrile seizures occur in infants and toddlers up to age 6. They are real seizures and should be treated, and they do not necessarily mean that the child is epileptic. Additionally, participants should understand that atypical or non-convulsive seizures are still associated with abnormal brain activity. They are still considered to be status epilepticus when lasting more than 5 minutes, and they still should be treated in the pre-hospital setting in accordance with your local protocols.